A 32-year-old man comes to the physician for recurring headaches. 5 years ago, he had surgery to remove a thyroid tumor. His heart rate is 80 beats per minute and his blood pressure is 120/75. Which of the following is most likely to have its metabolism directly affected by this patient's condition? Choice A, glucose. Choice B, tyrosine. Choice C, tryptophan. Choice D, ceramide. Or choice E, methylmalonic acid. I'll wait 5 seconds and answer the question. So this will be a question that is very easy for some of you, but for the rest of you, you'll look at it and you'll have no idea what's going on. So these patients' headaches is actually a paroxysmal symptom from sudden hypertension caused by pheochromocytoma. And some of you are going to be like, how the hell was I supposed to know that? So the history of a thyroid tumor here implies a medullary thyroid carcinoma, which in combination of recurring headaches is a favorite way some question writers like to give a more difficult presentation of MEN 2A or 2B. So both MEN 2A and 2B can present with medullary thyroid carcinoma and pheochromocytoma. 2A additionally has parathyroid hyperplasia, and 2B additionally has mucosal neuromas and marfanoid body habitus. Doesn't really matter in this case because obviously I give you the medullary thyroid carcinoma and then I imply a pheochromocytoma from these recurring headaches, right? USMLE actually really likes presenting pheochromocytomas this way. They will give you a patient with a history of headaches and then you'll go and measure their blood pressure and it'll be normal and you're like, what's going on there? So pheochromocytoma obviously isn't always active. So if the question writer is being nice, they might give you something like, oh, the patient stood up and then suddenly his headache returned, or he stood up and then you measured his blood pressure as shooting through a roof before he sat back down and went back down again. That would be way more suggestive of a pheochromocytoma, but here I was a little bit more subtle about it. I just said he had recurring headaches and right now you're measuring him as having normal blood pressure. But the fact that he had a thyroid tumor should instantly make you be thinking about MEN type 2A or 2B. For those of you who are unfamiliar with MEN type questions, you'll look at something like this and you just think it's really vague. But once you start spotting it, you'll actually start seeing these questions very clearly and they actually become kind of easy. So anyway, that was a bit of a tangent, but like coming back to this question. So what is a pheochromocytoma, right? It is a tumor in the adrenal medulla that produces catecholamines. And of course, here I went a step further and I'm asking about the biochemistry of it. So you need to know that the catecholamine production pathway, which is phenylalanine to tyrosine to dopa to dopamine to norepinephrine to epinephrine. So choice B, tyrosine, is the correct answer. And of course, we could sit here and discuss just that one pathway for like 20 minutes, right? But I'm going to try my best to keep it brief for you, okay? Phenylalanine to tyrosine requires phenylalanine hydroxylase. Tyrosine to L-dopa requires tyrosine hydroxylase. Dopa to dopamine requires dopa decarboxylase, also known as aromatic amino acid decarboxylase. Dopamine to norepinephrine requires dopamine beta hydroxylase. And then norepinephrine to epinephrine requires PNMT, phenylethylamine N-methyltransferase. Look, I know some of you who look at this biochemistry stuff and you really hate it, but sometimes you just gotta sit down and memorize it, okay? Or you just gotta at least have a familiarity with it, so at least when you see the enzymes, you'll be like, oh, okay, I remember what that's for. In addition, you also need to know that tyrosine can take kind of a turn to homogentisic acid, which gets broken down into mallyl acetoacetic acid, requiring homogentisate oxidase, a deficiency of which will cause alkaptonuria. You also need to know that dopa can also take a turn to go to melanin, which requires tyrosinase, and a deficiency of tyrosinase can cause albinism. And of course, in this quote-unquote main pathway, phenylalanine, tyrosine, dopa, you can have a deficiency in phenylalanine hydroxylase, which leads to PKU, fetal ketonuria. You can also potentially have a problem with the coenzyme tetrahydrobiopterin, which would also lead to PKU. Now, look, here's the thing. PKU, alkaptonuria, and albinism, I don't think there's actually that many questions about these conditions specifically on the MEMBs that often. They come up from time to time, but I would say they're actually kind of low yield. But the thing is that I would say knowing the catecholamine synthesis pathway in general is pretty high yield. So in studying this pathway, you kind of also learn about PKU, alkaptonuria, and albinism at the same time. So this is one of those pathways I think it does pay for you to have a level of comprehensive understanding about it. Because you'll get questions like this. Well, they'll have catecholamines going wrong in some way, and then they'll just turn it into a second or third order question where they ask you, hey, what's a substrate that might be affected by this? The answer could have been phenylalanine. It would have been just as valid of an answer, right? So I do have an image on screen here of the pathway for phenylalanine and the catecholamine synthesis. This is taken from Dirty Medicine. I don't want to get too bogged down in explaining everything about this pathway. That was just a quick review for you. So let's take a look at some of these wrong answer choices, okay? Choice A, glucose. Glucose can be affected in a secondary fashion by catecholamines because catecholamines can actually increase gluconeogenesis. But in the question, I wrote asking you what is most directly affected. So even though you can say that yes, pheochromocytomas can affect glucose, it's not the best answer choice here, right? Because you have tyrosine as a different answer choice. Now, if you didn't have tyrosine as an answer choice here, or phenylalanine, or anything else from the catecholamine synthesis pathway, and you had nothing but distractors except for glucose, then maybe you can entertain picking glucose, but otherwise, it's not a good answer. Choice C, tryptophan, not related. You want to know that tryptophan is a precursor in the synthesis of serotonin and niacin. They especially like asking about tryptophan being a precursor to serotonin. So you definitely want to be thinking about this in, for example, carcinoid syndrome, which is the metastasis of tumors that secrete a lot of serotonin. And in those, you'll get symptoms of flushing, diarrhea, abdominal cramps, that sort of thing. Think about serotonin syndrome, right? You'll have similar symptoms to that. Choice D, ceramide. This is a distractor. You should be slightly familiar with ceramides being forms of lipids that are especially strongly associated with various lysosomal storage diseases. Again, we can make like a 20-minute video just discussing the lysosomal storage diseases. I would say overall, the lysosomal storage diseases are actually fairly low yield, but they're kind of in this strange no man's land where even though they don't show up as correct answers that often, they do show up as distractors fairly often. So it actually pays off to know the lysosomal storage diseases, if only because it helps you eliminate more answers. And, occasionally you'll get the actual question about them. I-cell disease is the one that probably pops up the most, which is a defect in N-acetylglucosamine phosphotransferase that cannot properly phosphorylate mannose residues on the mannose 6-phosphate position, which ends up causing enzymes to be secreted rather than being targeted to the lysosome. So in I-cell disease, you'll see high levels of lysosomal products in the serum, in the blood, and this can lead to coarse facial features, skeletal abnormalities, joint problems, mental retardation. Some other ones that come up more often are Chediak Higashi, which is technically a lysosomal disease and also an immunodeficiency disease. I mean, it kind of is considered both, which is where lysosomes of leukocytes cannot fuse with the phagosomes due to a failure of microtubule polymerization, which ends up leaving cytoplasmic granules inside leukocytes, causes recurrent infections, and partial albinism because the same microtubule defect that causes you to have an immunodeficiency in Chediak Higashi also causes it so that you cannot move melanosomes through the melanocytes, and that causes the partial albinism that you see in Chediak Higashi. And like I said, I don't want to sit here and talk about all the lysosomal storage diseases. We'll be here for another 20 minutes. But the last one I guess worth bringing up is Gaucher. That's probably the one that comes up the most out of the, I guess, core lysosomal storage diseases that you tend to learn about. Lack of beta-glucocerebrosidase leads to glucocerebrosidase building up in cells, and you'll get the very buzzy tissue paper macrophages. Anyway, try not to get bogged down here. Let's move on. Choice E, methylmalonic acid. Okay, methylmalonyl-CoA is produced in the metabolism of propionyl-CoA, and then methylmalonyl-CoA can be further metabolized into succinyl-CoA in the TCA cycle with B12 as a coenzyme. So if you have a buildup of methylmalonyl-CoA and also methylmalonic acid, it means you're either deficient in the enzyme itself, or more often, it represents a deficiency in the coenzyme, which is B12. So B12 deficiency leads to elevated methylmalonic acid levels, which is something that's pretty useful to know, because one thing that USMLE has tested on quite a few times is that they'll give you a megaloblastic anemia, and you'll be thinking, okay, is this B9 or B12 deficiency? And they'll probably give you something like methylmalonic acid levels. And if it's elevated, you can just say, okay, it's B12. Because both B9 and B12 deficiency can cause megaloblastic anemia, and it can cause elevated homocysteine levels, but only B12 causes elevated methylmalonic acid levels. Again, I can dive into all the detailed biochemistry of it all, but this video is already getting way longer than it should be. So bringing it back to this question, you want to know catecholamine synthesis pathway, and you just got to be able to ramble it off cold. You got to be able to say phenylalanine, tyrosine, dopamine, norepinephrine, epinephrine. You know, a lot of times with medical knowledge, you just got to put in the hours, okay? I hope you found this video helpful. I'll see you in the next one.